In 1641, physician Nicholas Tulp reported the case of Isaac van Halmal, a man who experienced particularly excruciating headaches. Tulp wrote that in the beginning of the summer season, Van Halmal would be afflicted with a very severe headache, occurring and disappearing daily on fixed hours. According to Tulp, the intensity of the headache was such that Van Halmal frequently said he could not bear the pain anymore, or he would succumb shortly. The headache typically lasted less than 2 hours, but Tulp did not document whether it was on one or both sides of the head, or whether it was associated with any other symptoms. In any case, Van Halmal is probably the earliest known report of possible cluster headache. Hello, I'm Ibrahim Imam and welcome to this episode of the Neurology Lounge podcast, which will be looking at cluster headache. Tulp's report was relayed by Mervyn Eadie in his book titled Headache Through the Centuries. Although Van Halmal possibly had cluster headache, Eadie wrote that this was not an unimpeachable case report. Rather, Eadie said it was not until 1926 that the earliest demonstrated unambiguous cases of cluster headache were reported, and these were in the monograph written by Wilfred Harris titled Neuritis and Neuralgia. Amongst the cases that Harris reported was a 25-year-old man who started experiencing severe daily attacks of headache when he was 19 years old. The pain was in the back of his right eyeball and forehead, and it was accompanied by lacrimation and reddening of the eye. Lacrimation is tearing. Harris added that the pain would last for an hour or two and would occur for 3 or 4 weeks every year. Harris, however, subsumed cluster headache under the umbrella term migraneous neuralgia, therefore leaving the disease still vague. It was not until 1939 that Eadie said Bayard Horton and 2 of his colleagues isolated cluster headache as a distinct entity from migraine, and then going on to name it Horton's headache. And it had to wait until 1952 for the disorder to be given its modern name, a designation made by Kunkel and colleagues when they defined the disorder's pattern in 30 cases. A modern patient perspective of cluster headache is that of Stephen Young in his memoir titled Suicide Headaches, Short-Lived Trips, and Saved Lives. Young first experienced cluster headaches in his early 20s, and these worsened in his late 20s. By his early 30s, he said the pain just dragged on throughout the winter and into the spring. He described a typical episode which woke him up from sleep around 3 a.m., starting as a sensation of pressure in his left eye socket. He likened this to the feeling that someone had driven a sand-encrusted nail through my skull before proceeding to twist it slowly. He described the hours of simply pacing the floor, waiting for the pain to pass. He initially thought he was having a sinus infection, but his doctor dismissed this and made the correct diagnosis. Young luckily had a 10-year gap before his cluster headache recurred. The above accounts all highlight the now recognized cardinal features of cluster headache attacks. These are that they are usually strictly on one side, have an abrupt onset and offset, and last 45 to 90 minutes. One of the best depictions of the onset and progress of cluster headache is that by John Niven in his book titled Oh Brother. He wrote that it started one morning in April 2004 when he was woken in the early hours of the morning by a headache. He said that it is agonizing, located directly behind my right eye, and that it feels like someone has driven a splinter through my eyeball and into my brain. In portraying his reaction to the pain, he said, I find myself getting out of bed and going downstairs, where I shuffle around, pressing the heel of my hand into my eye socket and whimpering. He also described his accompanying symptoms when he said, my temperature rises until I am lightly sweating. My eye is weeping. I feel sick, weak. He likened the increasing intensity of the pain to someone turning up a dial, saying that the pain reaches a crescendo of agony after about 40 minutes. He maintained that it is by some distance the worst pain I have ever experienced, and for a moment I fear I may be having a brain hemorrhage. And then he said, just as suddenly as it started, it stops, vanishes completely. But 2 hours later, the exact same headache recurred, and this time he said it was so severe as to be almost unbearable. He said he came close to banging his head off the wall, and the headache returned the following night and the night after that. He said the agonizing headaches wake him up about an hour after sleeping, and they last between 20 minutes to an hour. He described the splintering, stabbing pain behind the right eye as being strong enough to make you want to split your own skull open, the raised temperature, the weeping eye. Niven started taking Nurofen and aspirin liberally, but he said all to no avail. Nothing works. It was on the fourth night, weak and broken for lack of sleep, that he searched his symptoms on the internet, and the term cluster headache came up. And just as they started, he said the attacks stopped for 3 years. And when they returned, they were never in the severity of the first bout. Cluster headache attacks are also typified by their timing, a feature that was captured in the account of American writer Howard Fast, who wrote of his experience in his book titled Being Read, a memoir. Fast wrote that his cluster headache started when he was in prison, and he described pain so severe that he could hardly talk or explain. He wrote that each attack would begin at 3 or 4 in the morning, last an hour or so, and then vanish. He said that the headaches continued for 2 weeks, then tapered off, but he said 6 months later, when I was back home, they began again, lasted for some 2 weeks, then tapered off. He also observed that each set of attacks was longer than the one before. Fast's cluster headaches eventually came to a head one day when he said, I could not break the pain. He said from 2 in the afternoon until 2 in the morning, each headache was followed by another until the crescendo of pain was utterly unbearable. Luckily for him, a doctor provided him with oxygen, and he said in 10 minutes a miracle of sorts took place. The pain died away. As the narratives so far have shown, cluster headache attacks are usually accompanied by autonomic symptoms, which are conjunctival injection or reddening of the eye, lacrimation or tearing, nasal congestion or running, ptosis or a droopy eyelid, miosis or a small pupil, and eyelid or facial edema or swelling. The attacks are also typically accompanied by such behavioural features as restlessness and agitation, and they are typically followed by fatigue, impaired concentration, and increased visual sensitivity. Attacks of cluster headache can be triggered by a variety of factors, and this was illustrated by the case of Rafael Haussler, as he narrated in his book titled You Can't See What I Feel, Living with Cluster Headaches. Haussler's journey to a diagnosis of cluster headache took 5 years, and it came about when he searched the internet, not by a doctor. And in his case, physical exertion was a common trigger for his attacks. For example, he described how pain attacks develop during or after riding his bicycle for 30 to 60 minutes. Other recognized triggers for attacks include alcohol, GTN, environmental temperature changes, solvents, and odors. The overwhelming impact of cluster headaches on the lives of its sufferers is simply unimaginable. For example, Haussler's account conveys the sense of desperation that cluster headache evokes. Referring to the peak of his attacks, he said, "I am no longer alive, I merely exist," with death increasingly becoming a sensible alternative. This is why, as Niven discovered, cluster headaches are also referred to as suicide headaches. Haussler's story also portrayed the ever-present fear of cluster headaches during remission, referring to this as this sword of Damocles constantly suspended over me. The period of remission is also accompanied by the fear that the medication I use will no longer be available. Another dimension of cluster headache is the toll it takes on the emotional, social, and professional lives of its sufferers. This is vividly portrayed by David Luca Schiantarelli in his illness memoir titled Cluster Headache: All the Secrets to Tame It. Schiantarelli described how the headaches impacted him, saying, "They ruined my entire life, my actual existence, my job, my friendships, my moments of leisure, my mood, my social relations, and so on and so forth." For a long time, he explained, his life was just cluster headache. He said it raged both during the day and at night, and that every moment of my life was a real concentrate of fear and suffering. It was so debilitating that he said, "My recurring thought in everyday life was, alas, suicide as the only way out of that terrible situation." Once, he said, "I took a double-barrel shotgun, loaded it with one cartridge, put it in my mouth, and shot. Click! It all went black for a moment. Then I realized I was still alive and the attack had suddenly vanished." He explained that I had pulled the wrong trigger, the one operating the unloaded barrel. I suffered a strong emotional shock that made the attack subside instantly. The overpowering influence of the disease on its victims' lives is also portrayed by Fast, who asserted that nothing in a long and eventful life has had an effect on me as deep and profound as this awful disease. He added that I have lived with it on almost a daily basis for close to 40 years, and I'm resigned to the fact that there will probably not be a cure for it in my lifetime. But he said, at the same time, facing it has restructured my entire being and enlarged my life. It has given me an understanding of life beyond anything I had, a sense of compassion beyond what I had known, and it reinforced my pacifism. He also said, in spite of this illness, I've managed to live a fairly normal and creative life, and to this day, few people I know realize that I live with this syndrome. A family tendency to cluster headache was suggested by Niven's account, as his brother Gary suffered with the chronic form. Indeed, there is a familial history in 6 to 8% of cases, and this appears to be transmitted in an autosomal dominant way. Cluster headache may also be caused by congenital developmental anomalies such as a Kyrie malformation, that is when the back of the brain dips down into the spinal canal. Importantly, some cases of cluster headache are caused by structural abnormalities such as aneurysms, cerebral vein thrombosis, brain tumors, and brain infections. Other potential causes are such disorders as multiple sclerosis, and medications such as chemotherapy and warfarin. And among the lifestyle factors that increase the risk of cluster headache are smoking, alcohol, and illicit drug use. The remarkable effectiveness of subcutaneous injections of sumatriptan in aborting cluster headache attacks is portrayed by Haussler, who said that the day I first took a shot of Imigran will be a special anniversary for the rest of my days. He was later dispensed oxygen, which helped, but it was not the panacea he had hoped. He said he found that dried mushrooms relieved him of his headache, and then he advanced on to using LSD. Niven was also put on sumatriptan, but using the nasal spray, which he said abates the attack while it is happening, but it also seems to increase their frequency. He therefore said, I quickly abandoned it altogether and take to suffering through. As we have seen with the case of Haussler, the acute treatment is heavily reliant on triptans, typically sumatriptan and zolmitriptan. Oxygen may also be required in the acute phase, as we have seen in the case of Howard Fast. Other acute treatments that may be considered are nasal lidocaine and dihydroergotamine. And then there is the transitional prophylaxis prong, which is implemented to limit the duration of cluster periods. And the main agent used here is prednisolone, given in a tapering dosing schedule. And the last prong is the preventative treatment of chronic cluster headaches. Verapamil is the first choice here, and this was the most effective treatment that Haussler had. But verapamil must be used with extreme caution because of its potential effects on the heart. Other preventative drug options include lithium, topiramate, and frovatriptan. And there is a range of interventional preventative agents that may be considered, ranging from greater occipital nerve block and occipital nerve stimulation to gamma knife surgery and sphenopalatine ganglion ablation. These are strictly for the headache super specialist. To explore cluster headaches further, I will be speaking to Amanda Ellison, author of the book titled Splitting, in the next episode of this podcast. Thank you so much for listening to or watching the podcast. If you found it enlightening, why not like or subscribe to the podcast on YouTube, iTunes, and Spotify to make sure you don't miss the next episode. And whilst waiting for this, you may consider exploring my book, Surfing the Brain, or checking my neurology database website called NeuroChecklist. Thank you very much for your time.